Hello everyone, and welcome to our program today. My name is Russ Browder, and I'm a Senior Marketing Manager at GE Healthcare. I will be your host today for this webinar, The Road to Meaningful Use, Economic Stimulus Insight for Providers. We are delighted to have hundreds of you joining us today. This is certainly a hot topic and a very timely one for us to talk about with you. We have great presenters lined up for you today and plenty of information to share. As we get started, I would like to mention that we will leave some time at the end for question and answer with our speakers. We will be facilitating this using the chat feature on the right-hand side of your screen. Please feel free to submit your questions at any point during today's program, and we will do our best to cover as many of them in the time remaining in our 1-hour-long program. I'd also like to mention today's presentation is being recorded, and we will make the recording and a handout of the slides available to you online in the coming days. So please be looking for an email with a link to the recording. To get us started, I would like to introduce Mike Frigoletto. Mike is Vice President and General Manager for GE Healthcare IT, a business dedicated to delivering the portfolio of Centricity ambulatory electronic medical record and practice management products and services, supporting over 6,500 customers and more than 100,000 physicians. Mike, I'll now hand it over to you. Welcome to the program.
Thanks, Russ, and good afternoon to everyone. I'd like to thank you for joining us today for what I know will be an informative discussion. It's my privilege to welcome the hundreds of you on the line and to share with you how GE is committed to helping you take advantage of the tremendous opportunity that is presented via the High-Tech Act and the Economic Stimulus Package. With two goals for the next hour that we'll spend together. First, we want to let you hear directly from two industry experts about the latest indications for physician practices. Our second goal is to get the conversation started with you about how GE and our Centricity solutions can help you get ready starting now. Today, you'll hear from two great speakers about meaningful use, the legislation, and the coming incentives for healthcare IT adoption. We're pleased to welcome Mickey Tripathi as our first speaker. Mickey is the President and CEO of the Massachusetts eHealth Collaborative, a nonprofit collaboration of 34 leading Massachusetts organizations. He also serves as co-chair of the Health Information Exchange Work Group and is a member of the nationwide Health Information Network Work Group, two subgroups of the Health IT Policy Committee, which is charged with making recommendations about health information exchange to the Office of the National Coordinator for Health Information Technology in the U.S. Department of Health and Human Services. Prior to joining the Massachusetts eHealth Collaborative, Mickey was the founding CEO of the Indiana Health Information Exchange in Indianapolis. Our second speaker works closely with GE Healthcare's Washington office and standards team to direct our participation in various government and industry groups, help define and drive GE's advocacy agenda, and to coordinate responses to regulations and legislation, such as meaningful use. Mark is one of GE's experts on the topic, and he actively represents the industry, GE, and our customers on Capitol Hill. So thank you again for joining us today, and let me hand off to Mickey Tripathi.
Great. Well, thanks so much. And let me first thank GE Healthcare for sponsoring this webinar, and also thank everyone who's participating. Looks like there's over 220 attendees now, so it's been a terrific turnout and really appreciate it. So I'm going to set up the discussion by thinking about sort of the high level of meaningful use in the economic stimulus and how all of the sort of the big picture parts fit together, and then turn it over. First thing that's, I think, important to recognize as we sort of just lay the groundwork for this conversation is just, the backdrop of what we're trying to accomplish here is very, very complicated. I mean, these are, sort of exciting times, and like all exciting times, they're incredibly complicated and somewhat confusing. The base on which we're trying to lay all of these health IT investments that we're going to talk about is unbelievably complicated when you think about how it compares to the rest of the economy. And I just wanted to show you, just one, sort of set of statistics just to give you a sense of that, which is basically that our healthcare system isn't really a system at all, which is to say that it's incredibly fragmented. If you look at the physician base across the country, roughly 700,000 physicians, a large fraction of them practice in hospitals, many of which, 2/3 of which are community hospitals. And then when you look at the ambulatory side, something on the order of, so it's an incredibly fragmented market that we're trying to accomplish some really complicated things in as we think about sort of federal investments working their way all the way down to the clinician end users at the bottom of the chain here. So as we think about this, how do we sort of think about the program and how that relates to the providers at the end of the day? So when you look at the overall program, it's got a lot of sort of funds flowing through different organizations, and as you can see here, the funding flows are unbelievably complicated, as one might imagine, where you're talking about a lot of money and going into a very, very fragmented part of our economy. Another view of that would be, sort of a picture like this, which is on the next slide here, that I know doesn't clarify things so much as it just shows you a different view with sort of curly lines. But the point overall isn't to suggest that this is convoluted. It's more to point out that it's unbelievably complicated because this part of the economy and what we're trying to accomplish is very complicated. My view, of this is a little bit more simplified, and what I thought I would do is give you a sense of what the organization perspective is in terms of which organizations are playing a lead role in defining the policy as we go forward here in thinking about how we define meaningful use. So what you can see on the next slide is that there's a couple of different organizations that are involved, that have been involved up until now, they're still involved, but have been involved from a policy-making perspective in defining what we think of as meaningful use. Starting with the National Coordinator's Office, who I think all of you are hopefully familiar with, Dr. David Blumenthal, there are two advisory committees, the HIT Policy Committee and the HIT Standards Committee, which are federal advisory committees. Their role is to provide policy guidance and advice to the National Coordinator's Office, or to the federal government generally. But these are all volunteers. They are not policy-setting organizations. I think it's important for everyone to realize that everyone participating in those committees are federal advisors, but are not a part of the federal government in any way, shape, or form. Those recommendations have now sort of had one round of gestation, which is to say that last August recommendations were made about meaningful use requirements and technology certification requirements, and now we're starting to see sort of the fruits of that labor in the way of the meaningful use incentive rules, otherwise known as the NPRM, which was released by CMS in late December, and the so-called the IFR, or the interim final rule, which sets the standards for the EHR technology, or EHR components, I should say, as it relates to meaningful use. Those two documents are now out. I think everyone hopefully knows that. They were released in December, are now out for public comment. The interim final rule is technically final, although there is a 60-day comment period, so people can still offer comments on the IFR, which I would strongly encourage. The NPRM, which Mark is going to talk about after I speak, speaks to meaningful use. That is also up for public comment now. It is not final until the public comment period is over and they issue a final rule. But that public comment period ends on March 15th, so again would encourage everyone to submit their comments. The other thing that's going to come out is us, which is that box all the way on the left that says certification regime. That is basically going to define how does a technology vendor get certified going forward. What are the rules of certification, the frequency, the sort of the thresholds, which organizations will be defining the certification requirements, and importantly, which organizations will be doing the certifying. That's all yet to come and should be released sometime in the very near future by the National Coordinator's Office. One other vexing part of this is state Medicaid and the role that state Medicaid plays, because state Medicaid organizations can also define meaningful use according to state variations in their thinking around healthcare delivery in their particular states, which makes it a little bit more complicated as we think about this going forward. I mean, I think that at the end of the day, we're the laboratories of democracy. So given that a lot of state money goes into those Medicaid programs, it's just one of the things that we have to live with as a society. But it is another element of complexity here that we all need to take into account. My view of this is actually a little bit even more simplified, where thinking about the dollars, I think, is probably the most clear way, from my perspective, to think about the ARA funding. With sort of the principle of following the money, this slide depicts where the money is going. Now, one important caveat I would put here is that I have depicted here about $47 billion in expenditures. $45 billion as direct payments to individual providers, that's hospital and eligible professionals who are ambulatory physicians, and those are direct incentives from Medicare and Medicaid, with roughly about $2 billion in a variety of programs which are really designed to set the infrastructure to help facilitate the individual providers exchange through workforce development and a variety of programs. One caveat that I would put on this is that you'll see that the numbers fly all over the place. That even though I have $45 billion here, you may see $20, not $20, but $20 billion, $25 billion, $30 billion. The reason those numbers float around is that the statute only stipulates what the individual level incentives will be. But what it doesn't stipulate, and because it can't, is how many people are actually going to take the government up on its offer to take this incentive and achieve meaningful use and thereby get these meaningful use incentive payments. So that's why you see the numbers all over the place, is that the Congressional Budget Office or the Office of Management Budget or CMS may have a different economic model that has different assumptions about what the individual behavior is going to be of how many of them are actually going to go for the incentives. But be that as it may, the general principle I wanted to show here is that the vast majority of the money is in individual payments to providers, and that's an important thing for us all to recognize, I think. And Mark's going to talk in detail about that. If we just want to describe now three parts of this infrastructure that's getting laid. The first is the Regional Extension Center program that hopefully most of you are familiar with that program. That is going to be funded at about the $600 million level. I think they may have added some funds to make it maybe approaching $650 million when all is said and done, to fund roughly 60 regional extension centers across the country. There will also be a Health IT Research and Resource Center that will be sort of a nationwide coordination and knowledge sharing organization, and also to try to offer them tools, guidance, training, things that can be centrally provided that will hopefully provide some comprehensiveness and uniformity to the quality of services delivered across the country. But importantly, will hopefully reduce the cost so that every regional extension center isn't having to start from ground zero as they move forward. The details of that program are as follows. Each regional extension center basically will be given 4 years that will be structured as two-year contracts. And this is on the next slide, please. That have the first 2 years as what are called the direct assistance phase, where they'll essentially be given $5,000 per clinician to provide implementation services to get them to meaningful use. And each regional extension center was required to promise essentially that they would do that for a minimum of 1,000 what are called priority primary care providers. And without getting into the details, unless it comes up in the Q&A, a priority primary care provider is basically a primary care provider who's in a small practice setting, which is 10 clinicians or fewer. And then there are some other categories of FQHCs, rural health centers, and what have you. But the bulk of them, I think, are going to be in the small provider setting, small practice setting. The extension centers will essentially get paid on 3 performance milestones. So they'll get roughly $5,000 per clinician, and they will have to hit 3 milestones with physicians who are starting without an EHR, which is to say they'll get 1/3 of their payment on contract siding, 1/3 of their payment when the practice goes live on an EHR, and then 1/3 of their payment when the clinician is certified to have hit meaningful use. So it's because there isn't cash up front. First and foremost, it's all performance-based, and so they only get the cash after they've made the investment and gotten clinicians up and running. And also, I think all of us would agree is that the funding's pretty tight. Spend $5,000 per clinician to get them to meaningful use is pretty tight funding, given the overall goal here. The overall goal, though, of the Regional Extension Center program across all 60 is to get 100,000 priority primary care providers up to meaningful use by the end of the 2-year period. So I think all of us would probably agree that that is an enormous challenge, but is one that I think we would also hopefully agree would be well worth it in terms of the efficiency and improvements that will bring to healthcare if we're able to accomplish it. The other part of the federal program is Health Extension Center, which is what are the different business models of the regional extension centers, and just to give you a sense of what the spectrum of these might be, because as you see 60 of them across the country, you may be wondering, well, who are these organizations and how are they going to function? My sense, and this is just Mickey Tripathi's personal sense of the spectrum that we're seeing out there, is that there are some who are going to be kind of the implementers, which is to say it's a single organization that is going to scale up to provide these implementation services in their service area. And an example of that might be the Mass Health Collaborative that I had in our pilot projects. We did it that way with 3 communities we worked with. The Primary Care Information Project in New York City, maybe a lot along those lines, and the Regional Extension Center activity that they conduct in New York City. Another model on the other end of the spectrum is what you may think of as being the most sort of decentralized approach, which I would characterize as kind of a match orchestrator that brings together, recruits the clinicians, and then offers them the opportunity to hire an EHR vendor, a hardware vendor, an implementation integration vendor from a pre-vetted pool of vendors who they have brought to the table to provide these services. So it's very loose, gives the physician maximal choice in thinking about how they want those services to go forward, but obviously has all the challenges that you have with more of an orchestrated model rather than an organization that has a single organization taking the implementation all the way to the end. And in the middle are what you may think of as sort of an orchestrator model, which is characterized perhaps by the New York Health Collaborative approach in the rest of New York. And some others where there are authorized implementation organizations that are going to provide the full suite of implementation services that may be geographically based, may have another affinity group based or a particular practice type based like FQHCs, but is a little bit in between that implementer and the matchmaker. If we look at Health Information Exchange, which is the other dimension that's sort of being provided as an infrastructure to help physicians move forward to achieve meaningful use, every state is being given essentially an allocation of HIE dollars, and the first rounds have been announced. And basically the idea there, I think that again there's a general recognition that there's not enough money to accomplish everything that needs to be accomplished, but the idea would be that there ought to be a floor of HIE capability in every state, and the funding is really there to provide that core of HIE capability so that every clinician, hopefully across the country, will be able to achieve meaningful use, particularly as it relates to the interoperability of the country. We'll see how that gets further defined as the program matures. The last thing that I'd like to discuss just very quickly is the NHIN, because that's the other dimension here that I think is very important as we think about meaningful use. The Nationwide Health Information Network, as this slide depicts, is whereas some people have thought about it, in the past as being a thing, which is to say there are a number of organizations across the country that have been funded as reference implementations and have created a full software stack with a full capability for medication management or other types of fairly high demand or very demanding clinical transactions. There is a growing sense that perhaps we ought to think of the NIN less as a thing and more as a set of policies, standards, and services that enable the Internet to be used for secure and meaningful exchange, which is to say that there's a whole spectrum of exchange that needs to happen. Not every type of exchange needs that heavy type of architecture. The Nationwide Health Information Network can work and ought to be thought of. So when you think about in the work group context, what the work group has been thinking first about the meaningful use criteria. What is important in meaningful use, and looking at the stage 1 criteria, which were really about direct communication of patient data among providers, where you have the exchange for treatment or payment purposes, the sender and receiver are known, and the sender may or may not have a prior relationship with the recipient, but it is sort of more of a push where it's within an episode of care, which I think is a less demanding kind of use case than some of the use cases that have been thought of for the NIN architecture in the past. So the idea is that the NIN ought to support achievement of meaningful use in 2011 and beyond. When you think about how you think about the broadening of the use of the NIN, then the NIN becomes less about a particular sort of software configuration or a particular sort of implementation, and more about a broad set of policies and exchange concepts that can handle the relatively less complex types of exchange that's depicted here on the left hand part of the slide, which might just be lab results delivery, for example, or it might just be about pushing a referral, a primary care physician referral to a specialist, or a consult back, for example, all the way to the right-hand side, which may be a very robust model around medication management or having aggregated data to perform a number of sort of so-called pull transactions, where you actually want to be able to pull data that's been brought together from a variety of sources and is there persistently out of an episode of care. At the end of the day, the work group is going to focus over the next 6 months on a variety of kinds of transaction types in succession, thinking about the role of enabling organizations first, then about identity proofing and authentication, directories that enable any organization around the country to stand up health information exchange activities in a way that would be easier than they could be able to accomplish today. The idea of a trust fabric, and which is to say, how do we create sufficient trust among different entities so that they are willing to use the exchange to further their healthcare business, and trusted enough that they're willing to do that. And then finally, governance. How does all of that fit together so that we understand at the end of the day how it needs to be governed, and what can be state and local versus what needs to be national. So that's my sort of high-level view of the big rocks, as it were, of meaningful use and the economic stimulus. And now Mark Siegel from GE is going to talk about the details of meaningful use.
Thanks very much, Mickey. That was a terrific overview. So first, I'd like to just briefly review the regulations that have been driving much of what we're going to see happen over the next couple of years. There were 2 regulations that have been released. They were actually out December 30 of 2009. One from CMS, which we all know runs Medicare and the federal portion of Medicaid. That deals with meaningful use and the payment policies. And that's really the rule that's most relevant to providers. It's out as a proposed rule with a 60-day comment period that closes March 15th. And GE alone and with our industry associations and partners will be submitting comments. We expect a final rule later in 2010. I think people are saying kind of a May-June time frame, and we'll certainly look for that. Secondly, a rule from the Office of the National Coordinator, the ONC, dealing with standards and certification. The criteria for how products will be certified. That's out as an interim final rule, which means it actually legally has already taken effect, but also there's a 60-day comment period, and we do expect, and ONC has signaled that there will be changes. Finally, we're waiting and expecting, hopefully by the end of this month, a rule dealing with the testing and certification program. Exactly how these certification criteria will be implemented, how will the role of the CCHIT certification process change. We expect there to be multiple certifying bodies, for example. So with that overview, I'd like to talk a bit about meaningful use. And we can see how meaningful use stages out over 3 different periods. And each of the first 2 stages are expected to be 2 years in length. The first really is intended, at least the theme, is data capture and data sharing. The second, to build on that with advanced care processes. And the third, focusing much more on improved outcomes. Now let's look at some of the specific criteria and reporting rules for meaningful use. Overall, in terms of the criteria, there were relatively few changes from what the policy committee had put out over the summer and into the fall. Each objective now does have a measure, and that has added substantially to the number of measures. And as was expected, providers need to meet all of the objectives or measures. This is being referred to as all or nothing, and is a focus of comment. For eligible professionals, physicians, for Medicare and some other professionals for Medicaid, there are 25 distinct objectives and measures. Reporting for 2011 will be by one-time attestation, most likely through a secure portal from CMS, but they also indicate that could be through a claims process. For 2012, we expect attestation as well, but quality reporting potentially directly from the EHR. And now on the next slide, I'd like to just show you the meaningful use grid. This is the first page of how meaningful use is defined. And you can see moving from left to right, they move from policy priorities to care goals. For the specific objectives for eligible professionals and hospitals, and this for distinct measures. So many of those measures have a very high threshold. For example, for eligible professionals, the use of CPOE 80% of the time. Now, in terms of clinical quality measure reporting, CMS has indicated that they're not ready to accept quality data electronically from EHRs. So as with meaningful use generally, for 2011 at least, they're using for a one-time attestation. And that's important. Unlike the PQRI program where, in general, you have to do that on a claim-by-claim basis, would submit summary measures calculated from the EHR and then attest that you use the EHR to capture the data elements and to calculate the results. And if HHS can't accept them electronically by 2012, they would plan to stay with attestation. Now, in terms of some of the specific measures for eligible professionals, HHS is proposing a very large list of 90 overall core and specialty specific measures. For any one physician, for example, you would likely have perhaps 6 or 7 measures to report, but CMS, recognizing concerns by many specialties, added a large number of measures to cover many specialties, as well as 3 measures that they were treating as core, relevant in general across all specialties. Many of these are from the PQRI program, but unfortunately only HR. And we do expect that the numbers of these are to be reduced. CMS has really said as much. They had to sort of put the maximum number in the rule because it becomes hard to add things to a rule that you didn't already put in there. For 2011 and 2012, the proposal is that each eligible professional submits 2 measure groups, a core measure group, and then a specialty group as a subset of applicable clinical measures. And so you can see coming up on the next slide the actual 2 measure groups here actually. One, the core measures, and then an example measure group for pulmonology. And we would expect, based on what CMS said, that that measure group would end up being trimmed back to 3 or perhaps 4 distinct measures. Now, one of the most common questions that I've been asked over the past number of months is when can you do your payment? So one of the notable things CMS did, as they said, for this first reporting year for hospitals or physicians or other professionals, you only have to demonstrate meaningful use for 90 continuous days in that payment year, essentially a quarter. So for eligible professionals, you can first start demonstrating meaningful use for Medicare January 1, 2011. You can last start, and this would be, really kind of pushing the envelope, October 1 of 2011 to get that 90 continuous days. And this 90 days applies even after 2011 if, for example, you start pursuing meaningful use in 2012 or 2013. And what they've indicated is that payments will be on a rolling basis. So relatively soon after you're able to demonstrate meaningful use, and if you've hit the maximum So one of the things that CMS has looked at is kind of mapping out the stages by which you move through different levels of meaningful use towards 2015. They've indicated that if you start meaningful use in 2011, you'll have 2 full years in the first 2 stages before you move into stage 3 in 2015. If you start in 2012, you'd have the benefit of 2 full years in stage 1, but you'd only have 1 year in stage 2 before you move to stage 3 in 2015. And if you start in 2013, you have 1 year each in stage 1 and 2 before stage 3. And a reminder that for 2011, and if you start in 2011 or 2012, as an eligible professional, you are eligible, as the upcoming table shows, for the maximum amount from Medicare. As for 2011 and 2012 starts, the maximum is $44,000. And again, that is really a cap. So the actual amount is 75% of your Medicare allowables for a given year, capped at the amounts you see. $18,000 for the first year, $12,000 for the second, and so on. And you can see that for eligible professionals, the dollars really are rather front-loaded. And then penalties, if you're not in meaningful use, start at 1% of Medicare allowables in 2015, scaling up to 3% in 2017, although it can go as high as 5% if adoption rates are below targets. So some overviews of the incentive policies for eligible professionals. First of all, who are eligible professionals? For Medicare, it's MDDOs, DDSs, DDMs, podiatrists, osteopaths, and chiropractors. The payment, and you have eligibility of incentives for up to 5 years, starting in 2011, and the payment schedule is really driven by when you start. It's not driven by the particular year as we saw before. The maximum can go as high as $48,000 if you're in a health professional shortage area. And again, you have to show meaningful use for an EHR reporting period. Now, some of the other applicable policies. You have to meet all the objectives and measures. And one of the most controversial issues is for hospital-based professionals, those who would otherwise be considered eligible professionals. CMS has indicated, and they're following, this is their interpretation of the statute, that if you furnish 90% or more of your Medicare-covered services in a hospital inpatient, outpatient, or ED setting professional, and therefore ineligible for the incentives. And that covers about 1/3 of Medicare physicians, which is much larger than anyone had expected. And many of the comments that are being developed are looking at addressing this. And there was a recent letter from some senators indicating that this violated congressional intent. There will be a single annual incentive payment made electronically by your carrier. And as I indicated, they will be on a rolling basis. And as with Medicare payments generally, you can reassign these incentives, and you can reassign it to only one employer or other entity. Now let's look at what's going on with Medicaid. Mickey said that obviously is an important part of this program. The state Medicaid programs will administer the Medicaid incentive policies, although the funds are really wholly from the federal government. EPs do have to select between Medicare or Medicaid, and they'll have an opportunity to make at least one change. And also, if you're practicing in multiple states, you'll have to choose one for Medicaid payments. Now, in terms of who's eligible, it is a broader set of individuals. In addition to physicians, dentists, nurse practitioners, certified nurse midwives, physician assistants who are practicing predominantly in a PA-directed health center. And also, you cannot be a hospital-based professional, although you're exempt from that criterion if you're in one of the health centers. And also, notably, if you're involved in a Medicaid managed care program, you are still eligible. Now, you have to meet some annual incentives. 30% of your encounters for a 90-day period in the prior year must be Medicaid in order to be eligible for the Medicaid incentives. 20% for pediatricians being eligible for a reduced amount. So you're actually eligible for nearly $64,000 over 6 years, and you also have more flexibility in when you can start. You have to start by 2016. Pediatricians, if they're below the threshold, can get up to $42,000, but they get the full amount if they hit that 30% mark. There is a higher payment in the first year, and that was initially going to be focused on situations where you were adopting, implementing, or upgrading a certified EHR, but CMS proposes to also apply that to your first year of meaningful use. And then in later years, you can have an annual maximum of about $8,500 for most eligible professionals. You are also eligible, within limits, to get support from other sources towards your EHR, up to $29,000 initially, and then up to $10,600 annually in later years. And you can get it. And there's no cap if those contributions come from state or local government. And those payments can be assigned to your employer or to special state-designated entities that are enabling HIE use, or HIE or EHR use. Now let's very briefly talk about the standards and certification criteria. So again, this mostly affects the vendors and the products, but it's certainly something to be aware of. Again, this was put out in an interim final rule that was effective starting last week. And the final rule, there's more discretion on when a final rule is out. We expect it to be out around when the final rule on the CMS Notice of Proposed Rulemaking is issued. The certification criteria are intended to cover the minimum capabilities and standards needed for a certified EHR to support stage 1 of meaningful use. And so these are really much their certification, those of you who are familiar with CCHIT. And these standards, and really primarily through the certification criteria, will be the basis for testing and certifying so-called complete EHRs, those that meet all the criteria, as well as EHR modules, a module meeting one or more of the criteria. And the specific process for this is still to be settled. We do expect that the interim final rule, as I indicated, probably later this month, and we can expect multiple certifying organizations, again, really operating from a template established by ONC. Now here you'll see just an example of what some of the certification criteria look like for CPOE. And just to show you that it is at a much more general level than, for example, has been used by CCHIT, where it really focuses on you will need to demonstrate that the product can enable a user to electronically record, store, retrieve, and manage, at a minimum, 4 different order types. And so, again, at a very high level of certification. So that is a very quick run-through of a very complex amount of material. For more information on this, I refer you to the website of the Office of the National Coordinator. In addition to having access to the regulations, it's a great source for other things that are going on with respect to ARA and healthcare IT, including the work of the Policy and Standards Committee that Mickey was talking about. And with that, I will close and turn things back over to Mike Frigoletto.
Thank you, Mark, for walking us through those key details of meaningful use. You know, every day I have the privilege of speaking with customers like you, gaining a greater understanding of your perspectives on the changes in the industry and listening to your questions. There are a lot, but the questions I hear most often are about how the technology itself can impact your clinical workflow, how it can help you increase reimbursement and improve business processes, and how it can support and enhance your ability to care for your patients. In summary, it's about improved outcomes, which is our ultimate focus of working with you. So we entitled today's webinar, The Road to Meaningful Use. And in keeping with that theme, there are 3 key mile markers on this road, which we think of as your road to improved outcomes. They're selecting your EMR, your readiness for change, and demonstrating meaningful use to deliver those better outcomes for the long haul. I'll mention some of the key ways that GE is committed to supporting you in the partnership with you through the journey. Achieving meaningful use is more than just getting the right product. It's about how your practice can achieve the clinical transformation necessary to improve healthcare through the effective use of technology. So the first mile marker is where most of you are likely spending your time today. And I'll cover some stuff on this topic around researching EMR solutions to prepare you to submit requests for proposals, do demonstrations, and conduct site visits. You're looking to select the best clinical solution for your practice. And here at GE, we're proud to offer two leading solutions, Centricity Electronic Medical Record and Centricity Practice Solution. Centricity EMR is our electronic medical record system that enables ambulatory care physicians and clinical staff to document patient encounters, streamline clinical workflow, and securely exchange clinical data with other providers, patients, and information systems. We have over 20 years of successful EMR implementation experience in care settings ranging from solo practitioners to some of the nation's largest healthcare organizations. And our EMR is used daily by more than 35,000 clinicians. The solution is a complete integrated clinical and financial management solution that helps you take care of the whole patient from first visit to final reimbursement. It combines the power of Centricity EMR with our industry-leading practice management expertise in one complete solution. It provides automated workflow, a rules-based engine, and the business intelligence indicators you need to proactively manage your revenue cycle connected with your clinicals. I'm pleased to tell you today that GE's comprehensive offering currently supports the vast majority of ARA high-tech certification requirements, and GE experts like Mark Siegel are closely monitoring the evolving criteria to stay current with those certifying bodies. So let's walk through GE's time frame for certification and how that coincides with your timeline for planning. As we heard earlier, final Stage 1 meaningful use criteria and certification standards are expected to be released by CMS late in the first half of 2010. At GE, we are preparing to release incremental meaningful use ready versions of our ambulatory EMR solution that address all Stage 1 requirements once they're final. As most of you know, CCHIT is the mechanism today to help remove uncertainty and risk for physicians during their purchase decision of ambulatory EMRs. With the ARA criteria being included as they're defined, GE Healthcare's timeline for product certification aligns well so that you can pursue certification and be ready. We're preparing now to test our solution for CCHIT 2011 comprehensive certification, which is intended to be inclusive of and to exceed those requirements of ARA. We expect to make the certified releases available in the second half of 2010 to help customers be ready to demonstrate Stage 1 meaningful use in 2011. The time frames will be upon us quickly, so I cannot overemphasize the importance for you to begin today if you're in the research and selection stage of the process. I mentioned before that GE's comprehensive offering currently supports the vast majority of ARA high-techs and how GE can help. First, on quality metrics and meaningful use reporting, in 2011, you heard Mark say that reporting will be by attestation, and all of our customers will have access to GE reporting tools that comply with the ARA reporting requirements. Customers who are enrolled in GE's Medical Quality Improvement Consortium, or MQIC, will benefit from robust quality benchmarking and reporting capabilities and automated PQRI submissions. This is the powerful tool that many customers have been leveraging for years, allowing them to securely compare their practice against a database of de-identified information from over 14 million patient records. The MQuick database and reporting tool, unique from GE, will be an excellent way for you to report meaningful use data smoothly and effectively. Another key area of meaningful use is patient and family engagement. Customers have multiple options for sharing health information electronically to patients. GE offers Internet Patient Portal and Clinical Messenger secure email solutions, improving communication with staff and providers. A third area is interoperability. Our Centricity solution currently employs standards based on interoperability such as HL7 and CCD, or Clinical Care Document, and will continue to expand these capabilities to support any meaningful use requirement. GE offers comprehensive e-health solutions for practices looking to connect to a health information exchange either directly from their own EMR or from our e-health clinical portal. Other key measures that could support your efforts to achieve meaningful use include e-prescribing, lab and immunization registry interfaces, CPOE, and clinical decision support. Our solutions currently provide functionality for these requirements and much more, and we will work with your organizations to identify and meet your specific connectivity needs. The last thing I'll mention on this topic of how you can select the right solution is what GE is doing to help customers overcome the barriers of uncertainty and the upfront capital expense. I hope you have heard about our Stimulus Simplicity program that was announced last June. There are two components of Stimulus Simplicity. First is around financing, attractive 0% financing and deferred payments on new purchases. Second is the certification warranty, stating that we will pursue the product certification I mentioned previously so that customers on our most current versions will be in the position to demonstrate meaningful use. It's not surprising that similar programs are out there in the marketplace today. But when you compare, you'll see that they don't match up to what GE can offer, especially in the way of the payment terms, coming from a partnership with a single company, GE, through GE Healthcare and GE Capital. We've seen great interest from practices considering first-time purchases of an EMR because they have been motivated to get ready for stimulus incentives and because they've been looking to implement EMR technology for a while and recognize this is an excellent opportunity to align these unprecedented financing terms with the coming incentive payments. And the full tech, and feel free to contact us for more information. The next 2 mile markers are equally critical on the road to meaningful use for your practice. I spent a lot of time on that first mile marker of selection. The second is all about readiness, how you prepare your staff, identify EMR champions in your practice, and follow change management best practices. Because preparing for change is essential. With all the improvements and efficiencies that are possible with a technology adoption, it's up to you and your practice to realize them. Our professional services team is dedicated to collaborating with you and your organization to help you optimize your clinical, financial, and administrative workflows. With a common vision for your organization, we put GE Healthcare methodologies to work to help you navigate implementation challenges and maximize growth opportunities and develop strong leadership systems. We've leveraged our Lean Six Sigma expertise to do our solutions to take advantage of the features quickly and cost-effectively. This rapid implementation approach moves from initial kickoff to go live in as little as 10 weeks for Centricity Practice Solutions and less time for the EMR. It can help customers get up to running faster while still leveraging the best practices and change management expertise you expect from GE. The final mile marker on this road is meaningful use itself. This is where, after selecting an EMR and implementing it, you become meaningful users of your EMR, not just to receive incentives, but to achieve clinical transformation. And I hope it's clear that meaningful use is not really about the product that you purchase. It's about the clinicians using technology that enables you to achieve improved outcomes. At GE, this includes powerful tools you've heard of today, like MQuick, and which complements our EMR and actually help you report out on meaningful use. But beyond our technology, who are available to work with you to understand your needs and support your goals to sustain meaningful use. It is for this objective that it's important for you to not travel the road alone. At GE, we talk a lot about collaboration, how we partner with our customers, and also how customers help each other. First, we think it's important that providers are provided with a stable vendor that is committed to the same clinical and financial mission. At GE, this means people like Mark Siegel, who are busy advocating for fair and meaningful use standards. It's an exciting and unprecedented time for all of us in healthcare, and GE has been in the healthcare business a long time, and our healthcare IT business is central to that strategy. You can see this nowhere more clearly than in GE's healthy imagination and commitment, a $6 billion investment to improve quality, decrease costs, and improve access to healthcare. EMR and healthcare IT are absolutely central to the commitment, something you may have started seeing now on television during the Winter Olympics. Collaboration is also about how you can learn from other practices using the same solutions. The Centricity Healthcare User Group is an independent association of customers whose mission it is to empower Centricity users to maximize product benefits, thereby enhancing safe, efficient, and effective patient care. We work closely with our customers and we listen to our users on everything from what we to prioritize in our roadmap to how the product design can continue to evolve, focused on the clinician's experience of using it. We call this effort our Customer Collaboration Program. each of these things I've mentioned we're doing today for our customers, and we've been at work on most of them long before the economic stimulus package was ever conceived. I hope that all of this shows that GE is committed to partnering with you and helping you on your road to meaningful use, and to help you make improved outcomes a reality for your practice and your patients. I'd like to thank you for your time, and I'll hand things back over to Russ.
Great. Thank you, Mike. And thank you to Mark and Mickey as well for sharing your insights with us. We covered a lot of ground today, and we could certainly spend quite a bit more time on each of these topics. Hopefully you and our audience have gotten a sense of the key details of the regulations, the process shaping it, and how GE can help your practice along the way. We've received quite a few questions from you, so I want to thank you for those. And with the time that we have remaining, I would like to now turn to some of those questions that you've been submitting through our chat panel. Feel free to continue submitting them, and we'll address as many as possible in the next 10 minutes. Mark, we got a couple questions around CCHIT, so I think I'll direct these in your direction. A couple people asked about the changing role in CCHIT, and if they contract with an EMR vendor now that is CCHIT certified, are they automatically certified for meaningful use? And are there any other certifying bodies?
So CCHIT has indicated, first of all, that they are going to continue doing their more comprehensive approach to certification that they've been doing, and that they actually have that program running. Secondly, they've indicated that they intend to apply and they intend to be selected as one of the ARA approved certifying bodies for the ARA certification criteria. As I'd indicated, we don't know yet sort of what that process is going to be, but I think we can confidently expect CCHIT to be one of them. We also know that ONC is going to be encouraging other certifying bodies. I've heard of at least one other organization that sort of focuses on interoperability testing has said that they're going to try to do that, and there may be others. If you have a prior CC11 certification, it will be necessary in order to be eligible for ARA to update to one of two certifying approaches. One is CCHIT has indicated that they're going to do a comprehensive 2011 certification that will build on what they've done before, but will be inclusive of the ARA criteria. And so that will be a new product certification. Secondly, and the alternative will be products that seek to focus on only the ARA criteria. And again, as far as we know, prior certification will not carry you through to cover the specific ARA requirements. They'll help with many of them, but there's some that there will be need to be new criteria, and in any event, there will need to be a new testing process. So this is something to watch closely. Again, we can expect significantly changed.
Great. Thank you, Mark. Mike, a related question to that I think you can answer is around GE's approach. Can you explain GE's approach to CCHIT 2011 certification when some other companies are saying they've already achieved it, and just give us some clarification around the different strategies that are going on out there?
Sure. We followed the CCHIT requirements fairly closely, but Mark had shared there was a lack of clarity from the ARA side until the final rule was published back in December. And so our approach has been to wait until the IFR was published, and then CCHIT's interpretation of that, which came out in February, and then we would commit to our certification process based on those set of requirements. Because we felt that that would be the most stable and likely final set of our decision to follow that time frame and make sure we had as much clarity as possible on the requirements. Some other vendors may have approached it with an earlier certification, but they'll have to go back now and reapply to make changes to meet the current published guidelines that were put out back in February.
Okay, great. Thank you, Mike. Mickey, we received several questions during your presentation, a couple on interoperability. One says that given that interoperability is such an important part of demonstrating meaningful use, can a practice demonstrate interoperability without a functional regional HIE?
Yeah, that is a great question. So the answer to that is yes, but I think if there is a functional regional HIE, it would make that easier. So at least for 2011, the requirements are mostly about lab results delivery and the ability to prescribe, which neither of which requires an HIE per se. But for lab results delivery in particular, it's made much easier if there is some kind of coordination around lab results delivery that can make that more cost effective for both the source systems who are delivering the labs as well as the physician EHR users who are trying to get the interfaces up and running. The other capability I think that could be affected here is this transition of care requirement for some kind of structured medical summary document to be passed to the next point of care. I think in 2011, and Mark can correct me if I'm wrong, the requirement is just to demonstrate the capability to do that, which is to say that you need to have an EHR system that's certified that it can create the document, but how it is transmitted has to be based on standards. So it could literally be printed out and faxed to fulfill that requirement as long as the EHR system is capable of doing it in a standards-based way if there's a platform for doing so.
Okay, great. Thank you. We also received several questions about regional extension centers, and maybe just a point of clarification. Are the centers only going to be able to help primary care providers, or what about other specialties and federally qualified health centers?
Yeah, so the centers are receiving funding to provide implementation services for what are called priority primary care providers. The definition of priority primary care provider is that first off, it covers what we would generally think of as the primary care specialties, so the regular primary care specialties, plus pediatric practicing in small practice settings, which is 10 clinicians or fewer, or a federally qualified health center, or a rural health center, or critical access hospital, or other sort of safety net providers like in an underserved area. So the implementation dollars that are received from the federal government will cover those implementation services for that set of providers. The centers can provide implementation services to any other willing clinicians who would like to have those services. However, they won't be subsidized by the federal government, so they would have to pay whatever fee the Regional Extension Center would charge to have those implementation services provided. I will say that that for a lot of regional extension centers, they're hoping that that will be a part of their sustainability model going forward, because they're after the first 2 years, they're only going to get 10% subsidy for their implementation services at that point for priority primary care providers. So they'll be looking for some kind of sustainability model. The value for a clinician who isn't a priority primary care provider and is looking for these implementation services is that hopefully, if the Regional Extension Center is doing its business right, it's achieved sufficient scale and expertise and is required to be a nonprofit, such that it ought to be able to deliver those services at a relatively good price and quality point in the market. But we'll see what happens and which ones end up being successful at the end of the day.
Great. Thank you, Mickey. And I would like to, again, thank our speakers today for a fantastic presentation. We've received many more questions, but we want to be respectful of everyone's time to stay within 1 hour. Any other questions that haven't been answered, using the email address that you used when you registered for today's program. I want to thank everyone for their interaction using the chat panel, and some fantastic questions came through. On behalf of GE Healthcare, we hope that you found our program very helpful. This is just one of our many efforts to help keep you informed during these times of exciting change. As a reminder, we will share a handout and recording of today's program with you by email. Also, if you are attending HIMSS in Atlanta next week, we would love to see you, so we invite you to stop by and visit with us at the GE booth. That's booth number 7039 in Hall B. And as we close out the webinar, you will be directed to a survey that we are conducting about meaningful use. We invite you to take a few minutes to complete this now. This is a great way for us to continue learning about what is important to you and how we can conclude today's program. Thank you again for joining us today. Goodbye.